So we were asked to talk a little bit about steroid, and the first thing is I like to refer to the steroids as glucocorticoids because, as you know, steroid is a very lay description of what this actually is. And if you use this term glucocorticoid, you're telling me you're not talking about the mineralocorticoid activity of the steroids. And it'll remind you about the side effects, which are on the glucose side. So when we're dealing with glucocorticoid therapy in neuro-ophthalmology, the most common indication that we are using it for is giant cell arteritis. So patients who have giant cell arteritis need to have glucocorticoids. Normally, if they have vision loss, we're going to give IV or high dose oral. I prefer intravenous because it gets the levels up faster. And normally we're going to choose methylprednisolone as opposed to our colleagues in neurosurgery who very much like dexamethasone, Decadron. So for me, the rationale for using prednisone in the PO oral state and methylprednisolone intravenously are the mechanisms of actions for glucocorticoids on giant cell arteritis, and all of our inflammatory diseases in neuro-ophthalmology rely upon both genomic and non-genomic effects of corticosteroids. And what I mean by that is binding of the glucocorticoid to the membrane occurs in both genomic and non-genomic effects. Binding after the membrane into the nucleus leads to mRNA, and so we have translation of proteins, either proteins to suppress immune system or proteins to accelerate it, so we can repress, trans-repression, pro-inflammatory molecules, and we can trans-activate anti-inflammatory molecules. And those are the genomic effects. And those genomic effects take hours to days to get going, and they reach a saturation point very quickly in terms of the genomic effects on the DNA. So the things that we're using intravenous for are the non-genomic effects. We want the genomic effects, but the non-genomic effects really don't kick in until moderate to high doses. And so when we have non-genomic effects, these non-genomic effects are affecting membranes, membrane stabilization, and directly acting on the pro-inflammatory cascade in immune disease. So if I've got a patient who's going blind with giant cell, I want to get the levels up high so that I can get the non-genomic effects, including the membrane stabilization effects and the neuroprotection, and then we're going to maintain them on a dose that will maintain the genomic effects, which is the mRNA, DNA-driven trans-repression or trans-activation of pro- and anti-inflammatory molecules. So the choice is going to be based on potency and route. So hydrocortisone is kind of the standard number one potency. Prednisone and methylprednisolone, 4 is their potency relative to a 1 on hydrocortisone. But these synthetic molecules are going to have a lot less mineralocorticoid activity. So that's why neurosurgery chooses dexamethasone and we choose methylprednisolone to maximize the glucocorticoid immunosuppressive effects and minimize the mineralocorticoid effects that are going to be inherent in any kind of steroid. And so for giant cell arteritis, we're really talking about high dose intravenous if you've got vision loss, or high dose oral if you don't have vision loss. And that is our main indication in neuro-ophthalmology for corticosteroids. Now we have some other secondary indications. So for example, optic neuritis or neuromyelitis optica or MOG, myelin oligodendrocytic glycoprotein. Those also need intravenous steroids for the same reason. We're trying to achieve a total effect that is more non-genomic than genomic effect. We want that level to be high, and the dose has to be high, and the route has to be intravenous. And that's called pulse. So we give patients pulse therapy when we're trying to treat something acute, and we need high levels, and we need those non-genomic effects really quickly because the patient is no light perception or light perception vision. So that's NMO and MOG. And any inflammatory process where we can use the immunosuppressive effects of glucocorticoids, whether that's uveitis or sarcoidosis or ANCA or lupus, all of those, our go-to is going to be methylprednisolone. And in the acute setting, pulse intravenous methylprednisolone. So optic neuritis, GCA, lupus, NMO, MOG, everyone's getting pulse, 1,000 milligrams intravenous methylprednisolone, followed by oral taper with prednisone. The less used indications like traumatic optic neuropathy and non-arteritic anterior ischemic optic neuropathy are controversial, and we will not be covering those. So, in summary, you need to know that glucocorticoid is what I prefer to call steroids to differentiate the mineralocorticoid effect that I like intravenous methylprednisolone and oral prednisone for pulse therapy for the bad things in Neuro-op, the three-letter words GCA, NMO, MOG, pulse intravenous because we want to drive both genomic and non-genomic effects of the corticosteroid. And you should know that we are not using the relative potency, hydrocortisone 1, prednisone, and methylprednisolone 4, to drive the decision making, as opposed to neurosurgery where they are using dexamethasone, decadron for pretty much everything. We prefer intravenous methylprednisolone.